You know, when they first asked me what do I want my first CEU topic for the critical care cadre to be, I thought about it, and I thought about all the cool, sexy things we can talk about critical care, but I'm a very much a believer in just the fundamentals. If you don't, I don't think anyone here is old enough to remember Whitey Herzog, the St. Louis Cardinals baseball coach. What was he famous for? How did he lead the Cardinals in 1982 to the World Series? What did he do?
He always argued with the umpires.
Besides that.
I'm guessing he worked on fundamentals.
He was. It was called the monitor. Very good. I mean, this is why he's a chief. It was called Whitey Ball because Whitey Herzog, he didn't do any flashy tricks, moves. His players spent hours unpracticed doing ground ball fielding and bunting and the little things, the fundamentals, and it got them to the World Series, and of course they won. The rest is history. And being new here, I know a lot of you, but I don't know all of you super well yet, and I hope to do so very soon. But if you don't have the fundamentals down pat, then all the certifications and whiz-bang training you do and everything, it really doesn't mean anything. And so what I wanted to do for our first time together is start at A from ABC, which is Airway. And man, a lot of you have been paramedics for a long time. You're like, Airway for critical care? I mean, this should be a BLS class. But honestly, what I've seen in the field, and I'm not talking just here, I mean everywhere, paramedics can use some reminding sometimes about what is truly important when it comes to airway management. We've all been on horrible scenes where, well, first let me just ask you this. Have you ever had a difficult airway on the scene? Yes? Okay, I've had difficult airways in the emergency department. That is a sphincter tightening moment, right? Have you ever had a can't intubate, can't ventilate scenario? Yeah, I've had a couple of those in my lifetime as well. And if you're doing this long enough, you're going to have the same thing. And it is at that moment that you realize, man, it's on me. If I don't get this airway, then this patient dies, especially in the critical care realm where we carry paralytics. So once you push that paralytic, there's only one of two options. You get an airway, or you can ventilate them somehow, or at least oxygenate them, or they die. So those are a heck of options, right? So as a medical director, I really have a vested interest, especially in all of you, with the privilege of RSI, to have the fundamentals down pat. So the next time you're on a scene like this, which is really crazy, and you have a difficult airway, who is everybody going to look to? You, because you've got the critical care ribbon on your uniform. Okay. So what I want to do today is do the foundations, the fundamentals, an anatomy review, the why behind good BVM technique. I want to improve your techniques of direct laryngoscopy, and this is probably where we can gain the most ground, I think, is doing that. And so at my station, at the BVM station, it won't just be BVM, we are also going to do direct laryngoscopy. And I'm also going to introduce you to a new scope called a V-scope, which is a bougie introducer, which is truly nifty. If you like it, I'll talk to leadership about maybe introducing it for you as well. We want to review the rescue airway algorithm and what the perils of surgical airway management are. This is the low frequency, high risk kind of scenario where you can't oxygenate, you can't ventilate, and you have to do FONA, front of neck access, to get air into their lungs. And so we'll talk about that too, all right? So, and yes, a stated objective, we're gonna have a little bit of fun too. So if I ask questions, this is truly informal. I don't want this to be me talking at you for an hour. I want you to give me feedback. And I don't think this crew is very shy, so give me some feedback, okay? So I can summarize all of my medical training here. Air, goes in and out, blood goes round and round. The end. And that too, okay? Make sure you sign in to get your CEU. Have a nice day. But truly, when you think about everything we do in medicine, whether it's in the ambulance or the ER, it's a variation of this is what is causing a problem typically. And today, we're going to focus on the air goes in and out part. So tell me, what are some of the tools that we use to make air go in the lungs and bad air in the lungs come out into the air? What are some tools we use? This is the part where you come, Thank you. BVM, oral airways, what else? Eye gels. So that's a secondary, a supraglottic. You can do CPAP. You can do artificial respirations. What else? I don't think anyone said laryngoscope. That's a tool. Needles for needle cracks. Good. All kinds of stuff that we use for our airway tools. And so we're going to, you've been paramedics for so long that this is just second nature. And oftentimes we think we know everything there is to know about the nuances of these tools. And I'm hoping I can make you just a little bit better, sharpening, being more intentional about thinking about the optimal ways to use each one of these tools up on the screen. We have a ton of tools and resources here, and I just want you to be able to say that you know exactly the pitfalls as well as the advantages of each tool, when to use it, when not to use these tools. So starting with the humble BVM, right? It's a BLS skill. Why are we talking about it? I'll tell you why, because you and I both have seen some people use the BVM in some really janky ways. And so we start with the fundamentals. I will tell you right now that even as a critical care paramedic, the most important skill that you have is a BVM. Because if you can ventilate somebody with this thing, the emergency essentially is over. You'll have some time to then get definitive airways, but using this is a skill. And it's something that we take for granted a lot. It often gets overlooked because it's a BLS skill, so medics just kind of skip over and say, well, I learned that at EMT school. I don't have to think about it anymore. I just put the mask on there and squeeze that bad boy, we're good. And they think that the endotracheal tube is really the most important thing, which of course is a load of that. It's amazing what you can find on the internet pictures of. Weird. Destroying a perfectly good beach. So if you can BVM a patient, then you can oxygenate and ventilate a patient. But so is there a difference between oxygenation and ventilation? And if so, what is the difference?
Ventilation is more like getting the carbon dioxide out, and oxygenation is getting the oxygen in.
Oxygenation is literally getting the oxygen molecules into the alveoli, right? Ventilation is that mechanical process of moving air in and out, which consequently, you're removing the waste products of carbon dioxide out. Now, can you give me an example of when you're oxygenating somebody but you're not ventilating them? Well, yeah. How about airway, like an intervention that you do? The no desate, high flow nasal cannula, if they have no spontaneous breaths, that is an example of oxygenating somebody without ventilating them. What's another one? Yes. Yes, a needle crike. So you can do one without the other in these couple of examples, right? A needle crike. But probably the one that I think of the most is a needle crike. So this buys you a little bit of time. How much time does it buy you about?
12 seconds.
A little more than that. Probably at the most 15, 20 minutes at the most, but you can oxygenate somebody with high flow tube through a needle, but you're not ventilating them at all. And then after which point in time it can become kind of toxic. But say that you're on the middle of on the highway and you can't get anything, but you can get a needle because you know that you're going to be getting to the hospital pretty quickly. You're not in New Melly someplace. But you're on I-7, you can get to a trauma center relatively quickly. This can buy you 15 minutes or so. That is a way to oxygenate somebody, but you're not ventilating them. But just be cognizant of the fact that you only have about 15 minutes-ish or so, okay? So are there patients that are not good candidates for BVM or that you're going to say this is going to be a problem? What's probably the most common one? Well, facial trauma is one. The most common one I would suggest to you is facial hair, right? If you've got somebody with a beard like that, I mean, it's going to be hard to get a really good seal. It's going to be hard to really get the volume you needed around all that hair, and so you have to think about something else. And yes, we talked about facial trauma as well. Not a great BVM candidate. I mean, if you can see bubbles and you can get an airway directly through the trachea, you can, but needle insufflation may be something else that you can use, a needle jet insufflation. This picture, I swear, it's in every textbook. EMT, paramedic. What do I hate about this picture? I mean, there's many things, but what's the one thing, we're talking about airway here, what's the one thing I really don't like about this picture? I'll give you a hint. Is the esophagus really open like that? So let me show you an actual x-rays and actual CT scans of the neck. Do you see an esophagus? I mean, I see, what is this right here? That's a nice tracheal air shadow. Nice, widely patent, you know. What's that thing right there? That's the epiglottis. You can clearly see that, right? And this is a CT scan. You can see this. What's that structure? And this little, the vallecula, and here you see another tracheal air shadow. Do you see an esophagus there? I mean, did this patient have a esophagectomy? Why do we not see an esophagus on the X-ray or CT? Because in real life, it ain't open like, it's not a tube. In real life, it's a potential space. The only time the esophagus opens is when you swallow a food bolus and it's a muscular contractions that shove it down into the stomach, but it's not open. In other words, when we think about the fundamental rule of physics that air follows the path of least resistance, and if you start to put together all these things like airway alignment, axis alignment, a good BVM seal, should it take a whole lot of effort to squeeze the bag and put air in? No. We've all had patients where we look like we have a good seal, but we squeeze the bag and it's like nothing, right? I mean, it's like squeezing a brick. What do people, including ourselves, have a temptation to do? Squeeze harder. It's a natural human inclination. If we get a BVM on there and we try to squeeze and we're not getting anything, we will always squeeze a little harder. But that's because of what? What factors makes us do such silly things? Adrenaline. Number one cause, adrenaline toxicity. Number one cause of dumbness. Absolutely. What's another thing? What's contributing to the adrenaline dump?
Urgency of needing to breathe.
The urgency of the situation. Right? They are not breathing. There's somebody behind you saying, SATs are now down to 79%. Yeah, I know, Sherlock. You know? And there's always a white shirt or somebody saying, do you get the tube? You get the tube? Hey, he's not breathing. Yeah, I'm working on it here. It all contributes to that adrenaline toxicity, that adrenaline poisoning, and we do dumb things. And we like squeeze harder, okay? But you realize that, man, this is a wide open space here. And man, if everything is lined up and we have a good seal, it should be like very easy, okay? And if you don't, fix the axis, fix the seal, fix the positioning, don't squeeze harder. Now, in a tiered system, which we're kind of a tiered system in that we do have EMTs, first responders that help out, which are great. A lot of times, because BVM is just a BLS skill, who do we give the airway to? We give it to the first responder, the EMT, right? Which is fine. Or maybe the newer paramedic, even the paramedic student who's on with us. But I want you to understand, I want you to think about the consequences of that, right? If you have at your disposal, which here at SCCAD, it's amazing the number of resources we have on a critical call. I have never seen such an amazing, patient-centered response to critical calls. I mean, I was on a cardiac arrest yesterday. I counted our 2 paramedics, a critical care medic, 2 critical care medics. I had 3 firefighters, one of which was a paramedic, and a doctor there. And all for this one patient. It was amazing, right? But if you give the BVM, the airway, to the least skilled or least experienced person, and they started off wrong, that's a potential cascade for everything else to go not so well. So just think about that. If you do hand it off to a first responder, that's great. But you as the paramedic in charge or the most highly credentialed or certified person on scene need to have the wherewithal to say, hey, stop stepping on the BVM to get air in. Let's do something different, okay? Because you're going to be focused on some other task, and you can forget about that sometimes. So think about that. But there are 4 fundamentals that you have to very intentionally think about at the BVM level, which is you have to have a good seal. That's everything. A seal with the face mask starts everything or fails everything from the get-go. Number 2 is you may need an airway adjunct, like an NPA or OPA. Sometimes you don't, but more often than not you do. And then selecting one is equally important, because if you select the wrong one, you've just shot yourself in the foot. Number 3, low pressure. Number 4, low volume. And low pressure, low volume kind of go hand in hand, but they are 2 different things. So let's talk about the wide open path of least resistance and how we meet all 4 of these objectives. Number 1, seal. There are 2 fundamental ways that we typically teach a seal: EC clamp and 2 thumbs down. We've all learned EC clamp. Who here has learned 2 thumbs down as well? A couple of you? Okay, 3 of you? Let's look at the first one. EC clamp is the most common way to do it. What is wrong with this picture, and why is this one better?
One's grabbing soft tissue, one's grabbing actual.
Yes, this guy is basically choking this guy out with his, he's anchoring on his neck and trachea. But I'm sure you've all seen people do that. I'm sure you've all seen people do that. All right, and if that's what you see, that's one of the things that you, as the paramedic in charge, have to say, hey, off the neck, anchor on the bones, okay, on the mandible. That's what it was designed to do. So when your C is around the mask and your E is on the mandible, it should be on the bony prominences of the mandible, pulling that mandible up into the mask, not in the soft tissues. But how many times have you seen that? I've seen it a lot, and I still do. So be cognizant of that. This is why one of the up-and-coming new techniques for BVM is actually the 2 thumbs down technique. More and more schools are teaching this instead, which I like too. I kind of have smallish hands, and so it's actually easier for me to hold 2 thumbs down for 5 minutes or 10 minutes without my hand cramping up when I'm trying to do with one hand with the EC clamp. Make sense? If you, I encourage you in my station today to try it. I think you'll like it. But the 2 thumbs down technique is exactly what it sounds like. 2 thumbs down, pointing towards the patient's feet. You use all 4 of these fingers in each hand to then get underneath the ramus and pull up. And it is actually, for me, far more comfortable. You are splitting the pressure from one hand into 2, so you're halving, cutting in half the amount of force needed. It's more efficient, I think, because you're getting a more perfect round seal instead of just on one side. And it helps your hand fatigue and helps you hold that mask a little bit better and longer. So try that out in the lab today. When you're squeezing the bag, see if you can do with just your thumb and finger. Okay. And see how that feels. And look, even with only 2 fingers, he's getting good chest rise and fall. Number 2, adjuncts. So NPAs and OPAs, when you pick one, sizing it appropriately is always one of the most important things. If you get an OPA, for example, that's too short, what's it going to do to the tongue? It's going to roll it up like a carpet and push it back. And if it's too long, it's actually going to act as an airway obstruction. So it really does have to be sized appropriately so that it's not either an obstruction or rolling the tongue, and your NPA is the same thing. So make sure that you get it sized appropriately. Number 3, low pressure. Pressure means don't squeeze as hard as your adrenaline rush. It means if the airway is open, you saw for yourself the photos, it won't take much, it shouldn't take much to get air down the path of least resistance, and it won't take a lot of pressure or strength to ventilate them at all, okay? And we still see people doing that a lot of times if they're not familiar with proper BVM technique. And again, you have to be the one that reminds them not to do that, okay? And then low volume. Again, not the two-handed approach, but about how many cc's of air does an adult BVM hold? Approximately. I hear 1,000, I heard 1,500. So yeah, it's about, okay, and well, what is your typical adult tidal volume? Approximately. Yeah, male, female, a little bit different, right? But it's certainly not 1,500, okay? So yeah, it's about 1,475 for an adult BVM, right? 450, 500-ish for a male, 385, 400-ish for females. And all you're trying to do is this, tidal volume. Remember, what is your vital capacity? How do you define vital capacity? Vital capacity is what and what? What's the upper limit of vital capacity? I kind of gave you the answer here. So your maximum IRC or inspiratory reserve volume, when you take your maximal inspiration, as much as you possibly can, that's the top. And then when you exhale all the way, as much as you possibly can and get as much air out of your lungs, now you're at the bottom of your expiratory reserve volume. So your IRV, TV, and ERV equals VC, vital capacity. And what you often see is people giving patients almost their vital capacity with the BVM if they're not watching themselves. What does that do to CO2? Drives it down, and we already know that hypocapnia, especially in traumatic brain injury, is very, very detrimental. So we don't, even as low as 28, I believe, you start getting statistically significant damage and higher mortalities in TBI. So, and brain injury patients are some of the most anxiety-provoking of all, which people tend to then squeeze harder and faster. So they're hyperventilating, they're overventilating, and their mortality rates are going up because their CO2 is coming down, because no one is paying attention, no one's minding that part of the resuscitation. And it makes a huge difference. And so we try to avoid giving people their vital capacity. All you're trying to do is give them their tidal volume in a resuscitation, situation specific, of course. If they are herniating in front of you, that's probably one of the few indications that you could hyperventilate somebody a little bit. But even then, not past about 28 for end tidal. You follow so far? Cool. So it is a critical technique error to just force it, because here's the thing. Remember, we saw the anatomy where the esophagus is closed, it's a potential space, but can you stent it open? You absolutely can. Because now if you're stepping on that BVM, oh, and I'm getting air in, all you're doing is you're stenting open the esophagus and you're filling the stomach. What does that do? You've all been on scenes where you're like second in or whatever, and it looks like they're pregnant. The problem is it's a dude. So they ain't pregnant. They're, well, yeah, nowadays, maybe today, it could be, no. But what happens when you have gastric insufflation to the point where it's visible? What happens to intrathoracic pressure? What does that do to venous return? It decreases venous return, making your CPR less effective. So now when you have decreased venous return, your cardiac output goes down. So now all the great CPR we're doing, even with Lucas, you're shooting yourself in the foot again because their stomach is a basketball. So if you see that, just kind of as an aside, and you're second or third in, what can you do to help clinically if you see that their stomach has been distended? What could you do to help decompress that? Yeah, drop an OG, NG, something, and kind of try to decompress that. Increase the amount of air that's coming out of the stomach so that you can decrease intrathoracic pressure. You can improve venous return, improve cardiac output, make your CPR worthwhile. Okay, all these little things. Okay. I mean, all these things, we have not passed VBM yet. See how important this is? So make sure that you don't contribute to this domino effect of errors in a code. Don't be afraid, especially all of you in this room are the clinical leaders on the streets as critical care medics. Don't be afraid to tactfully say, we need to change something, we need to do something, we need to improve this patient's clinical outcomes by making a few adjustments. I think sometimes the therapeutic inertia that's happening on a call makes us hesitant to change things, and we shouldn't be. Okay, we shouldn't be. Okay. So when you think that air follows the path of least resistance, make some change so that you can improve clinical outcomes based on what you know here in the physics that we just talked about. Now, once you do get a path of least resistance established and you're ventilating, then just make sure also that regardless of what airway you secure, another tendency, because you're like, woohoo, I got an airway, is to hyper and overventilate. What's the difference again between hyperventilating and overventilating? Speed versus volume, right? So hyper too fast, over too much. And very often we do both, hyper and overventilate. So we want to avoid both. Now, a lot of studies have suggested that you can engineer out of the system the ability to overventilate by doing what? Using low volume bags, right? I'm hesitant to say pediatric bags because then it's like, well, this is not a child. I have personally just gone to saying low volume bags instead of pediatric bags. There are a lot of studies that have shown that it works. You can still hyperventilate if you're not cognizant of it, but even if you squeeze the whole thing, you're not overventilating because you can't. You've engineered that out of the system. Having said that, there is a recent study that came out, which I haven't really gotten to look into great detail, that suggests that overall it's still better to use an adult bag, but just use a thumb and one finger, maybe two, to kind of avoid the whole overventilation thing. I gotta read the study a little bit more to find out why, A, how good a study was it, and B, why was that? Because I'm trying to think, well, it's the same volume, so what does it matter whether it's coming from a small volume bag or standard volume bag? I don't know. The take-home message for you is whatever bag we're using, because I believe here we're still using traditional size bags. What we have shown is that by using just your thumb and a couple of fingers to squeeze one hand, you are reducing a lot the amount of volume that you're delivering. Even if you do squeeze it all the way, you're already reducing a lot of the volume that you're giving. So maybe think about that. We're going to try that in our station today. If you're not used to that, we're going to see how you feel, build some muscle memory using just a thumb and a couple of fingers to squeeze the bag instead of one whole hand. Heaven forbid, both hands. Okay. All right. Well, now we get to talk about paramedic stuff. Endotracheal intubations. But I would posit to you that endotracheal intubation is thought of as a single procedure by most medics. And I'm here to convince you that it is a series. It is a series of complex actions that culminates in plastic in the trachea, but it's actually a whole series of events, not a single procedure. The series I'm talking about is about 7 steps, each step having its own sub-steps, but the main steps are, number 1, patient selection. like choosing which patient to intubate. Remember, the best medics are not the ones who can intubate, they're the ones who know when not to. And if they're going to, how they're going to do it. Okay. Number two, once you've made the decision to do it, it's patient positioning. This is also very overlooked, very often overlooked. Number three, a visualization sequence with blade insertion, and it's way more complex than you realize. Number four, a knowledge of diverse anatomy types, which we'll talk about here in a moment. Number five, proper blade insertion. Not only the sequence of visualization, but the insertion itself. Number six, proper shape of your tube and how you put the tube in. And number seven, confirmation of tube placement. Let's look at the first one, patient selection. So what is the name of this scoring system? Very good. What does that mean? What is a so you have a student who says, what does Malampati mean? What does a Malampati class 2 mean? What are you going to tell them?
Grading the airway of how difficult it's going to be.
So 4 is really good and 1 is really bad? Oh, it's the opposite. Okay, what? So what's the difference really between like 1 and a 2? Like, so you're telling me it's easy, not as easy, kind of hard, and really difficult. Yeah, but what does that mean anatomically? What do I expect to see with a 1?
Class 1 is to be a more posterior airway, and the higher you go up is how much more anterior the airway is going to be. The patient with their legs supine or in the bottom position.
Okay. Anyone else have a?
It's more of like a predictor for what you can expect as far as the difficulty of your access to their airways going to be.
In what way?
As far as your visualization, your positioning, things you're going to have to use, it might help you in, are you going to select to do like a DSI, or are you going to skip paralytics because we're a class 4, and like, are we really going to paralyze this person's diaphragm when we know we're going to be facing an extremely difficult airway?
Okay.
It's one of several doorway assessment tools.
Okay.
Is it jaw mobility?
Expecting to look for cords versus expecting to look for cartilage.
Okay, I like that one too. Jaw mobility, that's probably a contributor as well. So all of you have the right pieces to what it is. I will say that formally, the Malampati classification is essentially a percent of glottic opening that you'll see, regardless of anything else, jaw mobility, anatomical distortions, what have you. It's a relative predictor of glottic opening, which consequently is a relative predictor of difficulty. Okay? So when I say someone's a Malampati class 1, you would tell your student, this means that when I put my blade in under optimal conditions, I expect to see a POGO score, percent of glottic opening, of 100%. I see the epiglottis, I see the false chords, I see the true chords, I see the posterior cartilages, I see everything, okay? A class 2 suggests a POGO score of about 50 to 60%, meaning I still see the chords, but maybe not 100% of the glottic opening. That should still be a relatively easy airway. I can get that tube all day long. A class 3 means I'm really seeing just the very bottom of the glottic opening, maybe 10%, but I'm not even seeing chords. I don't expect to see chords. I expect to see the posterior cartilages. I expect to see the glottic opening, but I don't really expect to see vocal cords. You follow? Class 4 is bad. I see 0% of glottic opening. All I'm probably going to see is the tip of the epiglottis. So then I'll know that just south of that should be the airway. Question?
Is that true also for camera devices, or is this based on only the camera?
This is based on direct laryngoscopy. Yep. So you can kind of, and that's a really good question actually. Has anyone ever extrapolated it to the newer D blades and video laryngoscopes like the McGrath or the any of the other video VL techniques? That's a really good question. But you should still know that even with that, a Mallampati 4 is through VL is probably not going to be as wide open even as DL does. You may get a little bit more. You may be able to make it a 3 with a VL, maybe, but it still is a predictor of some difficulty. So patient selection, and to your point, deciding whether you're going to do DSI or RSI is one of those decision points that you're going to make if you have someone who's a class 4, a true class 4. Okay. Now, there are things that you can do to make that class 4 maybe a little bit better, and we're going to talk about that in a moment as well. But still, it is a predictor of difficulty. So, how do you use that clinically besides deciding whether or not you're going to intubate somebody, whether you're going to do drug facilitated versus RSI? By the way, what does RSI stand for? Oh, very good. I think I heard it. Rapid sequence induction. A lot of textbooks get it wrong. It's not rapid sequence intubation. It's just rapid sequence induction. There's nothing fast about the intubation. The induction is quick. What's induction? When I say induction, what does that mean? I'm sorry?
Pushing the medication.
It's the speed at which you push the medication to include a paralytic. Rapid sequence induction presumes the use of a paralytic in most places. It means you are taking their airway and you're doing it in a rapid fashion. And the reason you do it that way is because, especially in emergency medicine, is because unlike a post-op patient, which has been NPO since the night before, and they've had a pre-op exam, and you know everything about them, in our world, we don't know anything about this patient. And they just finished some beer and pretzels 10 minutes earlier, and they have full stomach. And so we want to induce them quickly, get them paralyzed, get the tube in, but we're going to induce them quickly. So it's rapid sequence induction, not intubation. Good. So what this does, the whole reason for doing a Mallampati, if you have the luxury of getting this test, is it kind of lets you know what is the likelihood of me needing to pull the reserve parachute. Has anyone here been skydiving or parachuting before? I have not. I don't think I ever will. But if I do, I'm going to have 5 reserve parachutes. The point being that I don't think anybody would ever jump out of an airplane with 1 chute. They always have a backup, right? But it's baffling to me how many medics will go intubate somebody and push drugs and they don't have a reserve chute. You got to have the reserve parachute, but especially if you're going to be a class 3 or 4, you really ought to have a backup plan, which we'll talk about in just a minute. But that is the purpose of a Mallampati. Like the purpose of a Mallampati is not just, this is going to be, no, it's so that you can mentally prepare and pre-plan, what am I going to go to if I can't get this tube on the first pass? Okay. So the second thing, positioning. So now that you've decided you're going to intubate this patient, if you have even 10 seconds to ramp this patient a little bit, you can incredibly increase your chances of first pass success. So lining up the ear or the external acoustic meatus with the sternal notch of your manubrium is an amazing little technique that improves your percent of glottic opening a great deal. And you notice here that just a little bit of padding, and I have found actually that a full box of gloves is the perfect height. So if you happen to have a full box of gloves in your truck and you just put it right behind their occiput, that brings their ear and sternal notch almost perfectly aligned, and that makes your job way easier, okay, way easier. If you don't have a box of gloves, is there anything else that you can do in your truck to ramp them? What else can you do? Yes, just bring the head up, the head up of the stretcher up just a little bit, maybe 30 degrees-ish or so, and that will do the same thing. It'll line up their ear and sternal knots very nicely, okay? So when you think about it from a physics standpoint, you look at the axes being lined up, and when you leave their head on the table, the axes are all cattywampus, okay? They're not aligned. But when you do simply lining up the ear and sternal notch, the pharyngeal laryngeal axis itself lines up. So now all you have to do is kind of work with the oral axis. But having the two pharyngeal laryngeal axes lined up is amazing. And you can even see that with a pretty good quality mannequin, airway mannequin. Try leaving the head on the table and getting a view, and then put a box of gloves underneath the head and get a view. You'll be amazed at how much better of a view you got. See here, the ear and sternal notch are much more aligned. See that? So he's able to see a lot. You see a lot more. Mm-hmm. Yeah. Same in rear.
Almost a full
glottic opening, right?
Yeah.
Anyone ever do this on a routine basis? About half of you, it looks like. Okay. The other half, I encourage you to try it. Try it in the lab today. You'd be amazed. I'm hoping to get my cadaver lab again this summer, usually August. And if you ever get to do a cadaver lab, there's like 10, 15 different specimens. You should go to each and every one of them because all their anatomies are different level of difficulty is different, and it's really amazing. But you can see, I have the students all do this. Leave the head on the bed and then lift the head about a box height, and they're like, wow, I've never seen such clarity before. And it really does make a difference, okay? What's wrong here? And I'm embarrassed to say, we used to teach this. I used to teach when you intubate, you can kind of hang their head off the end of the table or just crank them really back. And it makes no sense when you think about it from an axis standpoint. I mean, we obviously got these, but that does not make your view any easier. If anything, it kind of restricts your view when you think about it. So the axes are not at all lined up. You're widening them, in fact, okay? You're not bringing them together. You're widening them. So this lady, it's interesting, the story behind this photo. She modeled for this picture. And at the end of the photo session, she said, you know what I'm going to do when I get home? Because this is really comfortable. I'm going to get a bunch of pillows and blankets at home. I'm going to sleep like this because she almost fell asleep during the photo session. She's like, I breathe great. This is wonderful. When people are in respiratory distress, how do they present? Yes, exactly. They're doing this because they're opening their own airways. People who can't breathe, they don't go lay down and put their head on the floor. They try to sit up and bring their head forward, just like this, okay? With the ear to sternal notch, I had a cadaver that was about this size, and it was impossible to intubate them like that. But the minute we ramped it, it was easy, okay? So you can do that with your stretcher. You can do that with the patient as well. Then, proper grip is another thing. I love doing airway labs because I don't say anything. I watch how people hold the laryngoscope blade, and I see 50 different ways to people do it. So one of the things I encourage you to do, and I would say that the majority of people hold it like this. Still, they hold it on the handle, which is it seems to make sense that way. And if you don't think about it, and if no one's ever challenged you on it, people are going to hold it like that. But what does that do from a physics standpoint? It makes two fulcrums, essentially. What I like to do is hold so that my fourth and fifth fingers are actually resting on the blade. And it's these three fingers that's wrapped around the handle. What does that do now? It makes the blade just an extension of my radius and ulna. It's one axis, and it's way stronger. Again, I encourage you to not take my word for it. Try it in the lab. When you hold it like this, I'm sure you can get the tube, you've done it for years, but it takes a lot more strength and you have far less control over the tip of that blade, which is what you're trying to direct into the vallecula, which is everything when you're using a Macintosh blade. Okay? It doesn't matter so much if you're using a wrong blade. Any Miller? No Miller people. Oh, you are, okay. You didn't say boo or anything like that, so I didn't know. So I'm a Mac 4 guy every day, and that's what I'm used to. I think most people use Macintoshes. So I say it from that. But even with a Miller blade, you have to be able to direct it, right? So having it so that the blade, regardless of it, is an extension of your forearm, man, you have so much more control. You're much less likely to rock back and much more likely to be Statue of Liberty type style, what you're supposed to be. And the other thing is elbow positioning. This is something I also like to see in labs. People are often like this, and they're doing this. When in fact, your elbows should be in, don't chicken wing it. Okay, you have a lot more control, a lot more strength when you keep your elbow in as you're intubating. Okay, I know these are little things that very few people think about, but it makes a huge difference. If any of you are shooters, hopefully you're not holding your rifle, like that. But you look at professional shooters, they're tucked in, right? And they have a lot more control, it's a lot more strong, and the same goes for if you're holding a laryngoscope blade. So try it in the lab today. Then use scissor technique, opening the mouth to use your mechanical advantage to get as good a mouth opening as you can, using the scissor technique, and then side alignment. Does anyone here not know what eye dominance they are? Like, are you right-eyed or left-eyed? Has anyone ever taught you about that? Does anyone here not know what eye dominance they are? If you don't know, you can, the little trick is, make a triangle with your eyes, look at something across the room, and kind of bring it slowly back to your face, and whatever eye you naturally gravitate to look through one eye, that's your eye dominance. Okay. I used to say, how do you hold a camera up to your eye? And people are like, especially younger ones, what are you talking about? When you take a picture, I just go like this. No one uses cameras anymore, back in the old days. But I had no idea what eye dominance, I had never thought about it until I was, many years ago, I was on the police range, and one of the instructors says, hey, Doc, put the rifle in your other hand. I said, but I'm right-handed, just do what I say. All right, and man, I shot a lot better because he said, hey, did you know you're right-handed, but you're left-eyed? I said, no. So I shoot long gun left because I'm left-eyed, which I never knew. So if you don't know, and if you ever see someone who's intubating and they're doing this, they don't know what eye they are. Remember, even if you're looking this way, you are intubating with one eye, I guarantee it. You're not using both. Okay? So you're using a dominant eye. So if you are right-eyed, you're going to be like this. But if you're left-eyed, you're going to be like this. And if you see someone doing this, they're probably trying to find out which eye they should be looking through. So just know what you are. I'm a left-eyed laryngoscopist, so that's how I'm going to look. That's what I'm going to look like. Then insertion. So many people still take the blade and they try to just kind of keep the Statue of Liberty handle up like this and kind of just put it in like that. When in fact, what you need to do, and you'll do this in the lab, that blade insertion is initially going to be down at the feet. And you're going to let the natural curvature of the blade come around to help you do your visualization sequence. And if you're not really cognizant about that, you're going to, just like a OPA that's too short and it rolls the tongue like a carpet, you're going to do that with your blade. I've seen it. People will try to just kind of go in, and they're not sweeping the tongue, they're rolling the tongue's getting in the way, they're flustered in an already stressful situation. When all you have to do, drop the blade pointing at the feet, and then walk it in. And that's where you apply your visualization sequence, which we'll talk about here in a second. Okay? Then, at this point in time, when the blade is now tilted up for the first time, and you're looking for the epiglottis, this is where the epiglottis is often camouflaged, especially the floppy ones. And you can't see where it is, and you're like, does this patient even have an epiglottis? Where am I? And sometimes you just have to wiggle the blade a little bit, and you'll see it moving on the back of the pharynx. I'll show you an example here in a second. Okay. But now, even now, the tip of the blade is not engaging the ligament just yet, because you can see that the epiglottis is still blocking the view, right? It is at the next point where now the handle has already been tipped up, but now you're tipping up a little bit more towards where the ceiling and wall theoretically meet, and you are inserting it into the vallecula, and it's the tip position, not the force of it, but where you're placing that tip that makes all the difference once you engage that ligament. So, you know, here I'm not moving my thumb at all. It's floppy. Just by pressing there, my thumb is already flexing up. The epiglottis is the same way. Okay, so that's something that a lot of people don't take full advantage of. They'll put it in the vallecula, but then they won't engage the ligament and flip it up even more. Okay, so tip position is the main determinant of that glottic exposure. Now here is the visualization sequence of most people. They say, put the blade in and lift, don't rock back, try not to break teeth, hope you see something that looks like cords, and then pray your tube goes in trachea, not the esophagus. I mean, I simplify a little bit, but for a lot of people, that's their plan. They're like, put the blade in, try not to rock back, look for the cords, and put the tube between the cords. But man, they've skipped a whole bunch of other steps in between. And because it's a series of complex actions, I would tell you that there's actually a predictable sequence that you need to say to yourself every time you're intubating, every time. I still do this in the emergency department. I'll say, okay, as I'm putting the blade tip in, I'm walking it through visually. Lips and teeth and tongue and dangly thing, you know, uvula. I look for the epiglottis. I look for the posterior cartilages, the interarytenoid notch right there, interarytenoid notch, the posterior cartilages. Then I look for the glottic opening. And the very last thing I look for are the vocal cords, in that order. And if you don't say that to yourself every time, one of these days you're going to miss it and put it in the goose because you didn't make yourself say these steps each and every time, okay? So let's look at the first one, tongue and uvula. So there's my tongue here, there's my dangly thing. I know that I'm going to get just past that, and I'm going to look past the uvula, and then I'm going to look for my epiglottis, okay? So where is my epiglottis? Yeah, you can see the back of it, but you don't see it as a distinct structure really clearly yet because it's kind of floppy. What it's doing is it's sitting against the posterior pharynx, and it's kind of hiding itself in there. But once you wiggle the blade just a little bit and maybe lift a little bit more, all of a sudden, there it is. Now you see the rim. You see the tip of it right there? Now you know that that's your epiglottis. I cannot stress enough, epiglottoscopy is its own procedure. Okay? This is epiglottoscopy. You want to see the epiglottis because whether you're using a Mac or a Miller or a Wisconsin blade or whatever, you have to know where the epiglottis is before you know, am I going above it or below it? Now, to a lot of straight bladers, I know that what they often do is they just insert the blade all the way in. They lift, and then they pull back until what looks like the airway pops into view. I know you know some people that do this, okay? And it may work 9 times out of 10, but that 10th time is going to be a doozy. If you do it the same way every time and force yourself to know anatomically where am I going, you're going to increase your chances of success 1,000-fold just by doing that. Okay? So now that you know where the epiglottis is, if you're using a Miller, you know that you're going to go right underneath there, advance, lift up. If you're using a Macintosh, you know that you're going to engage the vallecula and be sure to engage the ligament to flip that up. Okay? So next is the posterior cartilages and interarytenoid notch. Now, I love this view because I know that if I can at least get this, I can probably get a bougie in it at the very least, right? I mean, I love this view. It's not ideal if this is all I see, but I'm pretty happy if I can at least see that, okay? Now, you have to identify the posterior cartilages and interarytenoid notch because, again, you know that everything north of there is the promised land. But you have to be very intentional about finding those landmarks, and I'll show you why in just a minute. Number 4, there's the glottic opening. So we've identified the posterior cartilages, the interarytenoid notch. Now you're lifting a little bit more. You see the glottic opening. Now you really know that you can probably get this tube, which is great. But the last thing we're looking for are the vocal cords. The last thing, not the second or third, it's the last thing is the vocal cords. And notice, and I didn't emphasize this enough, I'm going to go back here. Each one of these slides has the corresponding, like where is the position of my blade and my handle. Okay, so at this step, when you're looking for the epiglottis, that's where it is. At this step, now you're engaging the ligament and flipping the epiglottis up. In the vallecula, now you're lifting up a little bit higher with the glottic opening, and here you're seeing the vocal cords. Okay, now you're at full view of the vocal cords, right? Now, what if you do everything right? You've positioned them, you've gotten patient selection, you've done everything right, but all you can barely see are just the posterior cartilages and the interarytenoid notch. That's all you see. Is there anything you can do to maybe help your view? Very good. So I heard Selleck maneuver, burp maneuver. These are all things, these are all variations of ELM, external laryngeal manipulation. We haven't even talked about that yet, but yes, that's another thing that you can do. The backwards, upward, rightward pressure can often help improve a decent view and make it a great view, okay? So bimanual laryngoscopy is really good. You know, what I hate about this picture is that the medic's right hand has a tube in it instead of where it should be, which is on the neck, okay, to optimize view. That's much better, right? Your other hand is helping to optimize your view. Someone else can hand you the tube, but you probably shouldn't start with it. Optimize your viewing conditions, #1 priority, then worry about somebody getting you the tube, okay? So this is the same patient. This is before ELM, and there you can see the laryngoscopist's hand kind of in the picture there. They're giving themselves a burp maneuver. Look how much better that view is. Here you can only see the interarytenoid notch and posterior cartilages, but now you can see even the vocal cords. I mean, that's like a 90% POGO score right there. So just from external laryngeal manipulation, make that a habit. All right, can we finally put the tube in? Yes, we can. Now that we know how to select the patient, position the patient, use our tools appropriately, guide the tools appropriately, what our anatomy is, now you're ready to put plastic in the trachea. So the first thing you're going to do, of course, is grab your tube. Is anyone here too cool to use a stylet? I've met a lot of those medics say, I don't need no stylet, I'm good. Okay. I always use a stylet, whether it's the satin slip stylet or a bougie as a stylet. I try and use something as a stylet. It's not a crutch, to me, it's an essential tool of your trade. That's why they make them. So I will say, even those who use stylets, a lot of them shape them this way because they think they're gonna, kind of arc it in there. What was that movie where they held the gun funny and the bullet will go around the corner? What was that? Yeah. So, Angelina Jolie, that's what it was. Yeah. Anyway, they think that they can kind of, like curve that tube around the corner and get it in the trachea. And I've kind of seen it done. They just got lucky and were able to do that. But when you think about, again, the anatomy, what makes the most sense? If you look at surgical instruments that are designed for narrow spaces, they are not shaped like a horseshoe. They're straight, like a spear, okay? These little alligator forceps, McGill forceps. What are McGill forceps designed to do? Get hot dogs out of people's tracheas or whatever, right? They're designed to go in the trachea. What's an endotracheal tube designed to do? Go in the trachea, okay? So, and it ain't curved. So it is the business end is straight. And so when you think about putting an endotracheal tube in someone's trachea, it's like trying to put it through a paper towel roll or a toilet paper roll and hit a target about the size of a quarter. Remember, your tracheal, your glottic opening is about the size of a quarter. Okay? So that's the target you're trying to hit. So if I were to say, if you're at a carnival game and say, okay, you're going to try to hit, if you hit the quarter out of that little tube, you win a big giant teddy bear. You can pick this straight stick, or you can pick a horseshoe. What are you going to pick? I hope you pick the straight stick. So when you're thinking about making your tube, it makes way more sense to make your endotracheal tube straight like a stick. What I then do is make a little hockey stick, angle at the very end. So your long axis dimensions are way skinnier that way than if you're trying to put a horseshoe in someone's mouth. Okay, so to me, straight to cuff with a little 35-degree bend at the cuff makes the most sense as to anatomically, how do you increase your chances of success to get in that trachea? So you also don't want to obscure your line of sight with the tube. In other words, a lot of people I'll see, they'll go in with their laryngoscope, they'll take their tube, and they'll be like, what are they doing? They're blocking their view, okay? So when you're shooting, you're not like, you're looking over your front sight. You do the same thing, but with the tube, what you're doing is you're going paraglossal approach. So you're going, as you can see on the right picture, there's the tube tip right there. There's the tube itself. And they're not blocking their view in front of their face. They're coming down the side with that straight endotracheal tube with little bend up at the end. Okay. Then, when they're at or near the glottic opening, what are they going to do next? They're simply going to drop that tube. So now you see where the tube is. They're just going to drop it, and when they drop the tube, what's the end of that tip going to do? Going to go right into the trachea. Okay? And so by doing that, if this is your line of sight, here's your stylet, there's the epiglottis, there's the trachea. Look at what that does when they just drop the tube a little bit. That point naturally wants to go straight into the trachea. You're just helping it along using physics and your proper tube shape as a guide to help it go in the trachea where it wants to go. So know your landmarks, watch each series of steps. I can guarantee you that if you don't follow your steps and you just put your blade in and you lift, and you see this glorious tracheal opening, and someone is your battalion chief or a fire chief or a fire captain, and someone said, did you get the tube? Do you see the opening? Do you see the cords? Do you see the trachea? But you put the tube in. What are you going to be tempted to do? I'd be tempted to put the tube in. Okay? This happened to me when I was an intern, I'm ashamed to say. You know, before anybody really taught me how to intubate, I was this brand new intern at Barnes Jewish Hospital, and the trauma chief said, get that tube in. You know, do you see the cords? Put the tube in. And I just put the thing in and thought, oh yeah, I see a great big opening there. Where to go? Right in the goose. Because if you look really close, can I convince you that that's really tempting to put a tube in there? It would be for me, under pressure with adrenaline toxicity, okay? But in fact, when you back up and the blade comes up back a little bit, what am I now seeing? I see 2 holes. What am I seeing? What was that? That was the esophagus, because that's the trachea. Okay, what am I seeing? What am I seeing here that I didn't see here because I wasn't thinking about it? What am I seeing there that I'm not seeing here? Everything. I don't see posterior cartilages. I don't see an interarytenoid notch like I see here. I don't see a glottic opening. I don't see cords. Remember, the eye only sees what the mind knows. And if you're not intentionally going through your steps, lips, teeth, tongue, uvula, epiglottis, posterior cartilages, interarytenoid notch, glottic opening, vocal cords, you're not saying that to yourself as you go, you're going to see this. You're going to get adrenaline poisoning. You're going to put a tube in there, okay? And then a system, I don't want to call it an error, I want to say a system quirk that I found out yesterday during the cardiac arrest call I ran, is that our monitors, once you put the Lucas on, what graph pops up at the bottom? Your CPR box. What does it kick off? Capnogram, okay? What is the difference between a capnogram and a capnometer? A capnogram is the graph, a capnometer is the number, and you put it together, it's a capnograph, okay? So a capnography, by definition, is both the number and the waveform. If it's just a number, you have a capnometer. You don't have a capnograph, you have a capnometer. If you have just a nice line, that's a capnogram, but you don't have a capnograph because you don't know what the number is. You really need both, okay? So, to my slight distress, I was like, where's my capnogram? I want to see a 4-phase square wave. Well, doc, the machine won't let us because the CPR box is on. Now, we're in the middle of a freaking code. I'm not going to try to fix it then, right? I'm like, okay, file this away. We've got to fix this administratively later. Come to find out there is a way to do it. We're working on that now. Now, I was reassured that when we download the cardiac arrest, we can see everything. We can see the waveform, blah, 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 which is great. But I'm like, that does not help my paramedic at the time who really needs it. It's way less important for me to be able to see it a week later than for the medic at the time of the arrest to see it. So no matter what you think you see, you better have a capnogram. And we are fixing that here so that that system error does not perpetuate itself, okay? Because what if it said, well, yeah, but doc, we put the tube in and we got a 12 or 15 for a end tidal. Is it possible to get a CO2 reading if it's in the esophagus? Why? Yes, it is. Why? Absolutely. Absolutely. Any gas in the stomach, any gastric insufflation, all that stuff. But you don't have a graph to show you that it's flat. Okay. Even carbonated beverages, you know, burps that you get from just compressions, can give you a number. That number, I'll tell you right now, I don't care what the number is not reassuring to me. What's reassuring to me is a 4-phase square wave. Now, someone asked me, well, his end tidal was only like 10, so will we even see anything? What's my answer? Yeah, it'll be real shallow. It won't be nice, like a 40, but I'll see it. I should see unless it's 0, I will see a 4-phase square-ish wave. I'll see 4 phases. It may be shallow, but I'll see it. Okay. And the National Association of EMS Physicians very long ago issued a position statement basically saying that if you have 4-phase square wave capnogram, you are 99.9% certain that that is in the trachea. That is just as good as direct visualization of the vocal cords.
Doctor, so you know you can change the SpO2 to end-tidal waveform
Mm-hmm.
with the CPR box up there?
Yeah, and that's what we're doing.
Manual thing you have to do.
Yeah, and we're going to make it so that you don't have to do. Because I think the paramedics have enough to do on a code than to change things. I'm talking with them about making it programmed so that if the CPR box pops up, we can still have a capnogram someplace. Again, because I think you all need that more than anyone once you put the tube in, right? So lots and lots of people will put the tube in there and say, I saw it go in the trachea when they saw it go in the esophagus, because they were not consciously looking for every single anatomical structure that verifies that it's in the trachea. Okay? Doctors have done it. Everyone has done it at some point in time, unless you're very cognizant of it. Okay? So know your landmarks. Watch every single step. You do it the same way every time, and never again will you put plastic in the goose. Okay? So it is a series of complex actions, not a single procedure. Make sure you do it very intentionally. Okay? And again, no matter what you think you see, you have to confirm it with a capnogram, with capnography. That is the gold standard. That is the standard of care. Now, you all are very familiar with the capnogram. Where does inhalation start again? D, C. Where does where does exhalation start? A, B, C, D, E? Yeah, everyone thinks that exhalation starts at B. It actually starts at A. Why does exhalation start at A, not at B? Dead space. Okay. Remember, this is a favorite test question, and I love putting this on quizzes because everyone gets it wrong. Exhalation starts at A. Okay. Remember, when you exhale, when you first exhale, the air coming out of your mouth never participated in gas exchange, right? It's dead space air. So exhalation starts at A, but your capnometer won't pick up any gas exchange particles until you get past the dead space, and then you get the sharp uprise at B. Okay, so it starts at A, it starts being detected at B, and then you get your alveolar plateau. Okay, and why does it plateau instead of just go straight across? Why does it have a slight upward trend instead of just flat? Shouldn't it just be flat? Come on, you all are my ninja medics. You're my ninja medics.
Because there's still the CO2 is changing.
Yes, because can you ever fully empty your alveoli? No, you can't. So you will be continually, and the reason why it's going up is because the more you exhale, what kind of air is being sampled? Dead space, fresh, old? Old air. It's the older air that's now coming past that sensor the longer you exhale. So it's older air, it's more stale air, if you want to say it that way, but it's much richer, much more concentrated in crap. Okay, it's a lot more CO2 in it. So it doesn't plateau out. It keeps going up just a little bit. And if you could keep exhaling all the way, it would keep going up. Okay? But it doesn't, because at some point in time, you got to inhale. And then that's when D is, okay? And the number that flashes on the screen, is it at A, B, C, D, or E? Are you sure? What does ETCO2 stand for? End. End tidal CO2. So it's not B, beginning CO2, it's end. It's end. So it says D. Okay, the number that flashes on the screen, 38, 42, whatever, is that point. It's the end of your end tidal. Okay, so that's the number that flashes on the screen as a D. And then you have the sharp drop because now you're inspiring and the amount of CO2 being detected goes to baseline, okay? And then you exhale again and dead space air, so it's flat, no gas exchange, okay? Oh, this is a nice little review. I didn't plan on talking about capnography, but this is a nice little review, okay? So capnography is a measure of what? Besides metabolism, besides the fact that cells are on, capnography is most directly a measure of what? Yes, perfusion, there, ergo, let me ask you this. If the heart suddenly stops, what will your end tidal do? It should go to like 0, right? Because unless you're ventilating, but I mean, it should go to 0 because there's no what? There's no circulation. There's no cardiac output. So therefore, the answer is end tidal CO2 is a direct reflection of cardiac output. Make sense? So for y'all that do IFT, you're tootling on your merry way. You got about 20 minutes left and you're transferred to another ICU, and all of a sudden, their end tidal starts doing this, and then the next breath is lower. The next breath is lower. What should you do immediately? You should get up and start ready to do CPR because their cardiac output is dropping exponentially, right? There's nothing wrong with the tube. The line isn't flat or squiggly. It's still a square wave, but with every breath, it's going from this far to this tall to this tall. With every breath, they are fixing to arrest. Something happened to their cardiac output. So yeah, get up quickly. Check a pulse, make sure that everything's connected still, reassess them, do your dope mnemonic, all that good stuff. Good, okay. I sure am glad we don't have these little yellow as mellow, purple as schmurple things, because they were not real. It was better than nothing, but man, capnography is so much better, and a waveform is so much better. So much more information. Okay, cool. All right, so now, in spite of, again, doing everything properly, you can't get this tube in, whatever, you go to your rescue device. I believe our rescue device here is the iGel, yes? And in fact, for codes, it is allowed to be your primary, correct? I think before the iGel, what did you use? Kings? Yeah, we did too, Kings. Nothing wrong with the Kings, but my goodness, there was so many user error problems that with it just made it not useful. So what I like about the iGel, it is very hard to mess this up. It is just, put it in midline. That's about it. Now, when you pull your reserve parachute, because for whatever reason you can't get this tube in, the supraglottic airway like the iGel is a great adjunct. So you put this in, and even with the iGel, you have to still manage your rate and your ventilation. Make sure you're not hyperventilating. Make sure you're not overventilating, and you want to avoid hypocapnia as well. Okay. Then you have this nightmare scenario. Cannot intubate, cannot oxygenate, cannot ventilate, what do you have to do? You probably have to do front of neck access some way, okay, FONA. Whether it's jet insufflation, whether it's a surgical cryoc, of varying techniques, but you got to get air in somehow, okay? My friends, you have to know the landmarks. You have to know the landmarks. And you have to know that if you're not careful, a lot of people put the knife into there because they're feeling the hyoid bone instead, okay? I've actually seen it more than once. You're going for there, the cricothyroid membrane, which is just below, what's the common name for that? The common name for this point? Adam's apple. That's the common name for this point, the Adam's apple. It is the major prominence of the thyroid cartilage, okay? Now, when you are looking for that prominence, that Adam's apple is key because that's where you want the knife to go. That's the cricothyroid membrane. You don't want to go in the thyrohyoid membrane. You want to go in the cricothyroid membrane. How have most of you been taught to find the Adam's apple? I see you doing it now.
Go from bottom up.
Okay. And if that's the way you've been taught, that's great. I'll tell you how I was taught. I was taught to find the Adam's apple and then go down, and that first depression, this was the part where it's okay to touch yourself. Oh, dang, this is being recorded, sorry. You find the cricothyroid membrane, and that's where you're going to put the knife in, right? Now, for a lot of you dudes, that's a great way to do it because it's easy to find the Adam's apple. But for people that don't have as prominent an Adam's apple, and for people who have a lot of padding in between, it's hard to find the Adam's apple. So Rich Levitan, one of the gurus of emergency medicine airway, he teaches something called the thyroid handshake. He says, why on earth are we looking for this teeny tiny prominence when we've got this giant hunk of shield-shaped cartilage right there? Find that. And when you find that, you know that what's in the middle is the Adam's apple. So instead of doing this and hunting around for this little teeny Adam's apple spot, I take my thumb, my index finger, start the bottom up, and basically slide up until you feel, there it is, this giant hunk of cartilage, the thyroid cartilage right there. When you feel that giant hunk of cartilage, you know that right in the middle of that is the Adam's apple. Much easier to find than the Adam's apple for a lot of people. Now, I used to see Mike Matheny, the former Cardinals coach, on TV a lot of times. And I'm like, dang, I could do a cric from here because he's got this giant Adam's apple. I could also, even I could get an IV in him because he's got these ropes of veins. Cool, right? But not so easy for a lot of people. So you find the hunk of cartilage, find the middle part, Adam's apple, slide down, cricothyroid membrane. The single most important anatomical feature to find when you're doing a surgical airway, whether it's a needle or open, okay? So once you know your landmarks and know where you're going, then you want to start cutting. And I will leave you with this. I will say, if you cannot find landmarks for whatever reason, I don't know, you can't find it, why not just start cutting in the neck to find them? Which a medic did actually about 15, 16 years ago. Not here. But the state of Missouri, yeah, it was a mess. But both the case and the patient. But why not cut into it? Someone said it. Yeah, there's a lot of important stuff in the neck. And you just start slicing and dicing, looking for an airway, which this person did, and it did not go well, very badly, okay? So you really, really, really need to concentrate on finding the landmarks, optimizing your chances of success by finding those landmarks. You don't want to just go blindly cutting, okay? Now, once you do find the landmarks and the larynx, what I like to do is actually vice grip, like this is the head and this is the feet, and I feel their neck here. I will vice grip it and almost pull it up out of the neck, bring it anterior, and I won't let go, ever, because I've got it now. Okay, and I've got basically the thyroid cartilage in my hands, and I can feel the Adam's apple. I reacquire the landmarks, cut, reacquire, go through the membrane, reacquire. So after every cut, reacquire. And you'll do this in the lab this afternoon. You'll reacquire, put your tube in or put your device in, whatever that's going to be, okay? Now, here's the thing. Remember how we talked about external laryngeal manipulation? The fact that the larynx is very movable is great when you're doing direct laryngoscopy. It really sucks when you're doing surgical airways. You don't want it to move when you're doing a surgical airway. So vice grip that sucker. Do not let it move. Make your surgical cuts, okay? You're going to make typically a vertical incision. Why vertical? Honestly, just because it's more forgiving. You know, it's more forgiving. You can find, you have a lot more leeway to find the cricothyroid membrane, that's all. Once you find it, you'll make your typically horizontal incision then through the cricothyroid membrane, and then you can insert a bougie, which is great, or you can, if you have a big enough opening and you are confident that you've got it, you can put the ET tube straight in, like a little 5 or 6/0 tube in. You can use a Shiley if you actually have an actual trach tube in, which is great. I love the bougie technique because once you got it, and you can just slide it over. Attach your BVM, begin oxygenating and ventilating the patient. Now, I'll give you some clinical scenarios where front of neck access might even then not be your best option. What are you worried about this gentleman here? Clearly, he's had radical head and neck surgery from a possible cancer. That anatomy is going to be very distorted. You may not be able to find landmarks, and there might be nothing you can do. This guy, wow. If you roll up on him on an MVC, you can't get an airway. This is a nightmare. I mean, you can do the best you can, but that's going to be hard. This actually is one where the V-scope may actually be very useful. If you've never seen that or heard of that, I'll show you that to you in my lab. A really nifty new device coming out. These, facial trauma, again, depending, the neck may be open. If you can see the hole actually, you can actually access it directly. Otherwise, front of neck access may be what you need. Micronathia means it's a chromosomal defect where they have no jaw, basically. And so, like, how difficult is it going to be using a laryngoscope blade there in micronathia? Very hard, right? Very hard. Maybe even front of neck access might be affected as well, okay? What is Ludwig's angina? Anyone know?
It's a condition where the patient has a history of a decrease in their immune system, and they get some type of like minor trauma or stuff where bacteria starts to grow and starts to cause swelling.
Yeah, essentially it's usually a odontogenic source, so a tooth, a bad tooth as well, and it gets infected. And the submandibular space is relatively loose, and so there's a lot of room for pus and infection to just fester. It's warm, it's got lots of room to grow, and it becomes really ruddy and firm. And if it spreads beyond the trachea, which, as you can see, this one does, that can make it almost impossible to get front of neck access. That's also a nightmare scenario. If this patient needs intubation, if we have the luxury of time, we'll do it and send it to the operating room where head and neck surgeons can be standing by. They have something called an anterior commissure scope, which is the V-scope that I'm going to show you is kind of a pre-hospital version of that. But they will also have a full surgical table ready to go and open the neck surgically and try to get an airway. So we talked about the standard options, but there's also a Seldringer technique over a wire. This is a cuffed endotracheal tube. You know what I mean by Seldringer technique? Open it? Sure. Where you basically, it's like you're doing a needle crike. You find the cricothyroid membrane, you just punch right through it. You point it towards the feet. You'll take your wire. You feed your wire in. And as you can see now, your wire is in the trachea. Once you make a little skin nick, you'll leave the wire in the trachea almost like a bougie, right? You leave the wire in the trachea, and then you would take your trach tube. So now your wire is sitting in the trachea. You would then put this through. Once the flange is flush with the neck, head is here, feet is there, right? You'll then take the wire and the introducer out at the same time. Now you just inflate the balloon and you just put your BVM up here and you've got an airway. So it's a little less bloody. I like this technique. If you're used to an over-the-wire technique, it's pretty fast. But this is just one of several ways to get an airway in the trachea. So that's a Seldringer technique. It's over the wire. The Rush quick trach, I don't have an example of that, but you know what a quick trach is? It's basically this, but instead of the wire, you have a giant needle coming out, a super sharp giant needle out. You punch the needle through the trachea in, and then you just pull the needle out, and it's in. No wire.
We had those before the control cranks, and we had several failures with them. It was almost like
Yeah.
sharp enough to go in.
I personally don't like the quick trachs because, my goodness, it's like a giant harpoon, and if you back wall it, I mean, it's huge. I personally have never liked that. I like the over-the-wire technique a lot because I do over-the-wire for everything, for central lines, for you can do trachs, you can do art lines over a wire, all that stuff. The next one is the control crank, which we have here, and we have some of those to practice as well, which is really cool. I don't and will not plan to prescribe a technique that you must use for surgical airway. What my protocol will say is use the procedure technique in which you have been trained and credentialed to do. So you want to come in and get, if almost everyone here is signed off on the scalpel bougie open technique and the control crank, great. You want to do Seldringer technique, especially for my critical care group, I can get everybody certified and credentialed at one of our training days, and once you're signed off, you can have that. And that's another option for you to use. But whatever you feel is more comfortable for you, what you want to use, can use. Okay. Control crank, you all are familiar with this. Has anyone used it in real life yet? Not yet. Okay. But you know the theory behind it. You've got the hook built into the scalpel, and of course the biggest fear once you access the cricothyroid membrane is losing it and not knowing where to put your trach hook. Well, Dr. Levitan took that out and said, well, we'll just make the hook part of the scalpel, which I thought was genius. So this is what it looks like from the inside view. He actually put a camera in the trachea as he's doing it from the outside. And so this is the head, this is the clavicle down here. He's going to actually find the cricothyroid membrane And because the blade is it's double bladed, there's no need for a vertical incision. He just finds a crack with our membrane and punches through it once, okay? And that's what it looks like from the inside. So the blade is in, there's the blade, an inside view from the camera and the trachea, and then he's sliding the trach hook down, and there's the trach hook popping over the scalpel that's already in the trachea. Now he has positive control of that trachea with the hook, and there's a picture of the hook hooking onto the trachea from the inside. Now that he has positive control, he can just put the bougie loaded trach tube in, and then now that it's in the trachea, he takes his introducer out, he then secures it, and you can find a video of this on YouTube. If you Google control crack cadaver video, you can find it. So, in summary, being mastered the BVM, just because it's an EMT skill doesn't mean it's not important. You have to be the best at it. It allows for both oxygenation and ventilation. You might use an airway adjunct. When you do your endotracheal intubation, remember, it's not a single procedure. It's multiple complex series of decisions and steps. Always have a reserve parachute for failed airways. Don't be afraid to go to front of neck access if that's what you have to do. And the adage is, when should you do a surgical airway? Probably when you think about it. Like, if you think I need to do one, that's probably when you should start.